You did. All right. Good evening, everyone. I'm Laurie Ledley, the founder and president of Valley Sleep Center. And I'm so excited tonight to welcome Dr. William Arnold. He is live out at Abrazo Health talking about weight loss surgery. So if you're on our webinar, feel free to participate and ask a question. And if you're on Facebook, you can ask a question there as well. And when he's done presenting, we'll get all your questions answered. So thank you, Dr. Arnold. Thank you, Shelby, Connor, everybody who's there live. We can get started.
Thank you for setting this up. I appreciate it. I have to say, it's kind of funny. My coordinator, Elena, she sent me a text earlier today. She said, okay, she said that you were called Sleepy Valley. And I said, I'm pretty sure they don't call themselves Sleepy Valley.
I love it. That's the first time I've heard that, Sleepy Valley.
Awesome if they were called Sleepy Valley, but I'm pretty sure they don't call themselves Sleepy Valley. So
it's
yeah,
definitely the Sleepy Valley. I love it.
Anyways, again, thank you for setting this up. My first name's Will, my last name's Arnold, and I am the director for the weight loss program, surgical weight loss program at the Abrazo Arrowhead Hospital. And I am very happy to do this presentation. It's something that I frequently do for my own patients. We typically have a number of group visits set aside every month for people who are interested in surgery, thinking of starting the process, for people who are, midway through the process, and then for people who even like post-operative. And I really do feel like they benefit substantially from, doing these visits in a group setting because it's a shared experience. Patients can oftentimes they'll hear questions from other people that they never really even thought to ask. So I really encourage people, if they have any questions whatsoever, even just marginally related to medicine, I don't mind, just please ask. I'm happy to talk about any facet of medicine, surgery, weight loss surgery, whatever you want to know. I'll do my best to answer, okay? But what I can tell you is that the weight loss program here at Abrazo Arrowhead, we offer a number of different types of operations and treatments for weight issues. Typically, people who are considering surgery for weight loss, they usually have to meet some certain criteria in order for insurance to cover weight loss operations. And so I'll tell you that most insurance companies will cover weight loss surgeries for anyone with a body mass index of 40 or above. And what that basically translates to for most people is usually carrying around an extra 100 pounds. So just kind of a rough estimate is that, generally people over 80 to 100 pounds excess usually have a body mass index of 41. There are several body mass index calculators, but basically it's just your height in centimeters divided by your weight in kilograms squared. And trust me, you don't want to figure that out on your own. So it's best just to use a body mass index calculator to find out what your real body mass index is. Insurance companies will often consider it for people who are lighter, down to a body mass index of 35 to 40, who also have some fairly severe weight associated problems like diabetes and high blood pressure, obstructive sleep apnea, fatty liver, elevated cholesterol and lipids, anything that they can attribute to excess weight is as commonly considered as what they call a weight associated comorbid problem. And so they'll oftentimes approve it for patients with a body mass index down to 35. In the past, even 4 or 5 years ago, when people were thinking of weight loss surgery, it was almost always one of two procedures. Geez, this is not a very good. What the, it almost makes it worse.
There was a green marker that might come out a little easier.
It literally made it worse.
You see this as a permanent.
Right, give me a Sharpie.
Yeah.
Sorry, that's better, kind of.
Okay, there you go.
Oh, stop using that black pen. Right.
Yeah.
So in the past, when people thought about weight loss surgery, it almost always was either lap bands or gastric bypasses. So when you're talking about a lap band, it would be, here's your esophagus and let's say your normal stomach, right? It's an odd asymmetric organ like this. What they would do is they would take an adjustable band and they would place it around the top part of your stomach like this. So they would wrap it around the top part of the stomach, and this would be connected to tubing that was actually connected to a small port under your skin. And this is something that seemed like a good idea on paper. They could add fluid to the band to make it tighter. It had a little capacity to take on fluid that would actually make it tighter if you added fluid, or they could access it with a needle and remove fluid to make it looser. And the idea was that you would swallow food and it would be trapped, at least temporarily, in the upper part of your stomach behind this belt. And it would trick your brain into thinking that your whole stomach was full. Like, you ate a small amount of food, and because the top part of your stomach was full, the idea was that it would trick your brain into thinking that you had filled the whole stomach. And so it actually seemed like a pretty good idea, at least on paper. Unfortunately, these are plagued by one particular problem, is that the stomach itself is so muscular and robust and active that it's very unlikely that even if this is put in position perfectly, that it will stay that way over time. So the problem with lap bands is they would oftentimes be simply shrugged off the stomach and it'd end up looking like this. You'd have esophagus, you'd have your lap band encircling your lower esophagus, and then the rest of your stomach. And that would do no good for weight loss, because all it would create was trouble swallowing. So patients would complain that they were having trouble passing food down there, just swallowing food. And most of the time they get blamed, for eating inappropriately or too much and things like that. It's not associated with any fullness or satiety, though. They'd struggle to eat regular food, but it doesn't make your stomach feel full. It's just a belt around your esophagus. And so paradoxically or unexpectedly, they would start gaining weight. And the reason why is because they would start resorting to things that will go past here, through here, liquids, highly refined, highly processed foods with little substance to them. And that's not very satisfying. So paradoxically, they would actually end up getting more calories in that way, because it would tend to be foods that, they normally wouldn't have eaten. It would have been better to not have the lap band at all and just eat healthy food, So I probably see anywhere from 10 to 12 people a month who get referred for lap band problems, and it's almost inevitably this is the issue with them. It's an easy problem to fix. It's easy to identify, and it's easy to fix. I almost always recommend removing that lap band and converting it to something else, a more modern procedure at the same time. If anyone ever has heard that they have to have the band removed and then later on go back to convert it to something, I wouldn't recommend that. It's not really worthwhile. Oftentimes, that is simply a way for programs to get 2 procedures out of you instead of 1, and it's really not in your best interest, and there's no real medical or surgical reason to do that. It's safe to remove it and do it all at the same time. So that's, if anybody's ever encountered that issue, please, don't fall victim to that, okay? But lab band issue is very common. The other procedure that was commonly performed and is still performed today, but with a little less frequency, is the old gastric bypass. And a lot of people have some passing familiarity with this or know somebody that had this done. This operation was done for years, being the gold standard for weight loss operations. The way that this works is they would start by partitioning your stomach. They would divide the stomach here to create a small little pouch of stomach. This might be about the size of an egg. And then the rest of the stomach would still technically be left in place, but food would never enter this part of the stomach again. It would sit there, it'd have its own blood supply, it would survive, but it wouldn't actually accept any food anymore. So obviously you can't just catch its dead end there. So what you have to do is you have to go further downstream and divide the small intestine. You're going to bring this portion all the way up to that little gastric pouch, okay? So this part comes all the way up here and is sewn to this pouch up here. So the food is going to, you're going to swallow food. It's going to go into this little gastric pouch. It's going to fill up very quickly because it's very small. You're going to be full very quickly. And then the food's going to travel down through this small intestine. Now, all of the digestive enzymes, bile, pancreatic juice, gastric secretions, that can't dead end here. So to complete the correct plumbing, you're going to have to plug this into here so that all those secretions can join the food stream just further downstream, okay? Here's the idea. Small stomach, eat less, fill up easily. Then your food's going to travel down through here, but it hasn't really mixed with any digestive enzymes. So it's not really being broken down into, it's components that can actually just be absorbed into your bloodstream. So it's going to travel through some of your intestine without really being absorbed. It's not until it meets up with all the digestive enzymes downstream that real digestion starts to occur. Now, I've drawn it. It looks pretty short here, but in reality, from here to here is about 150 centimeters. The idea was that you'd have some restriction here, eat small portions, be satisfied. And then in addition, some of the food that you ate wouldn't quite get absorbed because it was traversing through a portion of your small intestine without any enzymes. Eventually real digestion kicks in and you absorb stuff. But this is why people would have to, take supplemental vitamins and minerals and would have problems sometimes with B12 and require B12 injections. It's because some of these are absorbed in this part of the intestine and now they're not being absorbed. So this is still performed, but I have several biases, several reasons why I don't like this operation. My personal feeling is that this operation has become outdated in favor of better operations. I've performed hundreds of these over the years, but I've really stopped doing these operations in favor of ones I think work better, maintain a healthier relationship with food, and have significantly less side effects than this one does. I'll go over some of the reasons why I really don't favor this operation, and you can compare it to the other ones I'm going to mention in a minute, okay? Number one, this here, this is just an opening. You sew these pieces together, but it's a static opening. There's no smart regulation there. Normally, your stomach, when you eat and drink, it's controlled. The exit of food is controlled through what they call the pyloric valve. That valve stays closed. Your stomach churns, mixes the food, breaks it down into smaller components, mixes with acid and enzymes, and then it's slowly released into the small intestine, okay? It opens and closes, meters out a small amount of stuff from your stomach into your small intestine. That's how your small intestine was designed to receive food, partially processed by the stomach and then delivered out in small little aliquots. This has no regulation. You swallow food, very little processing occurs in this tiny part of the stomach, and it goes straight into your small intestine, okay? Your small intestine was not designed to accept food like that. So when people say gastric bypass causes dumping symptoms, what they really mean is that a rush of food, sometimes sugars, fats, anything really can cause it directly into your small intestine, overwhelms your small intestine. It creates cramping, bloating, sometimes nausea, sometimes diarrhea. Sometimes people will get like flushing or kind of a racing heart rate. It's caused by that lack of smart regulation, just food just transiting too quickly into your small intestine without being pre-processed. So what did we used to tell people? Well, okay, that kind of sucks, but maybe, if it happened with ice cream, maybe you just shouldn't eat ice cream anymore. But it wouldn't happen with just ice cream. It could happen with like eggs, it could happen with a number of things. Or sometimes people would develop lactose intolerance because of this. And it really, I think, is a very, very unhealthy approach to say, well, maybe you shouldn't just eat those things. It can create a lot of maladaptive eating behaviors, this dumping symptoms, and nobody really wants to have dumping symptoms. I mean, that's not really, I don't think that's a healthy way to lose weight, is to be, afraid of what's going to happen if you eat something. That's not what this is supposed to be about. This isn't, I like this because I think my approach doesn't create these maladaptive eating behaviors or food aversions or an adversarial relationship with food. That's what I'm trying to avoid. And this, I feel like this doesn't accomplish that. The other thing is your small intestine, it's not designed to protect itself from acid like the stomach. The stomach is great at protecting itself from acid. It can live at a pH less than 2, but your small intestine can't. And the way your small intestine deals with that is just beyond your pyloric valve. It has it's peppered with little cells called Brunner's glands that secrete bicarbonate to neutralize acid. So you take acid and bicarbonate, you put them together, they neutralize each other. That's why your small intestine isn't peppered with ulcers all the time. This part of the intestine does not have it. It's localized to this part right after your pylorus. So this doesn't secrete bicarbonate. This doesn't produce a lot of acid, but it can produce enough to cause ulcers on the small intestine. So they're called marginal ulcers. And at some point in your life, if you have a gastric bypass, there's probably about at least a 25% chance that you're going to get marginal ulcers, okay? Do they perforate? Usually no. Do they bleed? Sometimes, but most of the time they just hurt, and inevitably they heal, but they heal with scar tissue. So you have multiple rounds of ulcer and then healing, ulcer and healing. Pretty soon that little opening can turn into a tiny little opening because it scars down. So I just feel like these are completely avoidable problems, and so while this is still performed with some regularity, I really hope that as time goes on, that this gets kind of relegated to just history. I really don't think people should consider having this done anymore, okay? That's gastric bypass. So what do I really recommend? All right. What I really favor is two different operations, right? The easiest one to kind of wrap your head around is what they call a gastric sleeve operation. This is the most common operation performed worldwide nowadays for weight loss. And of all my patients who come in and are interested in the surgeries, probably about 80% ultimately, this is what they decide is right for them, okay? This operation, sorry, pyloric valve. This operation is simply resizing and reshaping the stomach. So we take a normal stomach and we're going to use a series of surgical staplers that seals and then cuts the tissue. And we're going to move up to create a small tube of stomach that's roughly the size and shape of a banana. All of this stomach here is going to be removed, not just partitioned. It's not, it doesn't stay in here like this one does. This is completely removed. And so what's left behind is a thin tube of stomach that looks like this. Okay. To give you some idea about the size difference, if a normal stomach holds about 1,500 milliliters, so 1.5 liters, this, I designed mine to hold about 150 milliliters. Okay, so that's an extremely small amount. One of the little stubby water bottles, you know, that you buy, those usually hold around 230 milliliters. So you can see it's substantially less than most people think it's going to be. The thing I like about this, or that why people like this, is because it's fairly easy to wrap your head around that operation. There's no rerouting of the small intestine. You maintain your pyloric valve. Food is still processed by the stomach and then slowly released out to the small intestine. Nothing's rerouted. It doesn't change your physiology. It still makes acid. It still makes enzymes. It does everything your stomach does now, except hold food. This outer part of the stomach out here, the part that we remove, this is thinner, it's stretchy, it's compliant. It's what allows you to eat a big meal at a restaurant and know you're full, but then still be able to tolerate like key lime pie and a coffee, you know, before you go home. I know from experience. So it's very compliant, especially this portion up here. It'll really stretch dramatically to accommodate more food. And there's an evolutionary advantage to that. You know, if you lived in an era where there was feast or famine, it was very helpful to have a stomach that would allow you to gorge on food, because, you know, maybe there was going to be times, you know, lean times to follow. But that's not really an issue for us. So we have these very stretchy parts of our stomach, but we don't need them. So removing that part of the stomach leaves behind an area of the stomach that's actually very thick and muscular and very resistant to stretching. So one of the downsides to having this is that it's very unforgiving. This part of your stomach won't stretch out to accommodate more food. So once you're full, it's a hard stop. And people know they're full. And they recognize full, and they feel full. It's not a trick like a lap band. They're full because their stomach is truly full. It's not just a trick like tricking your brain. They're full, but if they drink more or eat another bite on top of that, it feels terrible. It feels like there's no room for it and it got stuck, because literally that's what happened. And nobody eats that way because they were still hungry. If it happens to them, it happened by accident. They just misjudged it. They ate too fast, something like that. Or it's not something that happens every time you eat. In other words, that's not your trigger to stop eating. People stop eating when they're full, but occasionally they will just do one bite too much and then they become regretfully full. It doesn't mean you're throwing up or, you know, having tantrums. it just usually it looks like this. Oh, I've seen that look plenty of times. It's like that look of regret, like I shouldn't have had that last bite. But it introduces this unrelenting consistency. And that's why it works, is because it accomplishes what a diet does. A diet is just eating less calories or eating low, burning more calories than you're consuming, right? So you cut the calories down, that's what you do with the diet. The problem is that it's very difficult to cut your calories down to what these people average. These people average between 800 and 1200 calories a day. It's very hard to duplicate that on your own. You can do it. I can do it if I wanted to, but I probably couldn't do it for more than like 2 or 3 weeks in a row. I would very rapidly lose interest in starving, because that's what it feels like. 800 calories does not feel very satisfying. I can eat more than 800 calories just breakfast. So it is very, very hard. You could technically do it, but I personally don't know anyone with enough willpower to stick with this indefinitely. And this does it because you're actually full. You're not suffering by, continually telling yourself like, wow, you probably should stop there. You're still hungry, but you're telling yourself to stop. This tells you you're full and you really are full, cuts the calories down significantly. And this doesn't care where you are. It doesn't care if you hate everyone at work. It doesn't care if you're on a cruise ship. It is. Once you do it, that becomes like your augmented willpower. So, like I said, a very popular option. People often fear that it's going to create a situation where they're just hungry but can't eat. They fear that they'll just feel the need to eat like 12 times a day. And that is exactly the opposite of what happens. Most of the patients with this, on average, usually eat maybe 2 small meals and a snack a day. That's their average intake. And when I say small meals, I usually mean people at this could probably tolerate half of a small sandwich. Not a big thick hoagie or anything like that, but half of a small sandwich before they're full. There's no restrictions on the types of food that they can eat. In other words, like this, we don't have to tell people there's all these types of things they couldn't do. Doesn't apply. A lot of people hear or read that they can't drink out of straws, have carbonation, have ibuprofen, have caffeine, drink alcohol, have anything spicy or sweet. It doesn't apply to these because it's your normal stomach. It maintains its normal function. It's just different size. So we don't have to put all these restrictions that we used to put on these guys, the bypass guys. This creates a more normal relationship with food. And they're not plagued by dumping because they still have an intact pyloric valve that still regulates emptying, okay? They're not at risk for ulcers or anything like that either. This operation, we perform it through 5 small incisions with the camera, long, thin instruments. It takes me anywhere from about 37 minutes to an hour to perform, okay? There's no need to put a catheter in anyone's bladder. There's no tubes or drains. I always do the same thing every time. I use a flexible gastroscope to help calibrate the size of the tube or size of this sleeve. I pass it down just like the gastroenterologist does. I pass this down, I make it adopt the curve of the stomach, and I use that to help me create a sleeve that's narrow, but not inappropriately narrow. It also helps to avoid, this is a curve, so it helps to avoid kind of cutting in too close to the curved areas. So it helps to standardize it so that everybody kind of has the same size sleeve. You do not want to make these too big. You want to keep them really small. because that's what translates into like acceptable weight loss and then maintaining the weight loss over time. The other thing it allows me to do is at the end of the operation, one of the last things I do is I use that same scope, and the scope allows me to fill that, to insufflate air into this, and I fill it to max capacity with air underwater. I put this underwater, I fill it with air, and I look to make sure that it's airtight. Even the smallest air leak in that, you'd see it like you were examining a bicycle tube, for air leak. You pump it up, put it underwater, it'll show you where the leak is. That's exactly what I do for this. And I don't ever see any leaks, but I always test it every time because it gives me some peace of mind that everything's fine by the end of the case. And that's how I test it. I don't send people to radiology the next day to drink contrast. They used to do that in the past, to do a leak test. So the complication rate with this is extremely low. It actually has a lower complication rate than removing your gallbladder, which is a fairly common procedure in most hospitals. Removing your gallbladder actually has a higher risk of complications and even death than this operation does. So it's not, I tell people, if you were willing to have your gallbladder removed, then this is not more dangerous than that. It's a little less, actually. So people shouldn't have reluctance to consider these surgeries because of fear of problems or complications. Okay. What else? I get a lot of referrals, probably about at least 30% of everything I do is revisions. I do a lot of revisions of operations, previous operations, really old ones. It's old-fashioned gastric sleeping operations, revisions of these, lots of lap band problems. But I don't get a lot of complications related to sleeves. I get sleeves that were made too big, like people had a sleeve somewhere at St. Elsewhere, and they lose some weight initially and then gain it back. And they, maybe interact with other who had a sleeve, and they say something seems off because I seem to be able to eat a lot more than my friend who had a sleeve. And they, they notice these things. They talk to each other and they say, how much can you eat? And they say, well, I'm full after this much. And, they say, well, I can eat a lot more than that without a problem. So they go talk to their doctor about it. And inevitably, what do they say? Oh, you must have stretched it out. You ate right through it. I hear that a lot, that people get blamed for stretching this out. In reality, if you do this correctly, it should be next to impossible to stretch that out. Okay. Technically it's possible, but you have to eat to the point of just absolute misery, overfill this thing over and over and over again in order to really substantially stretch that out. Okay. So is it possible? Yes, but it's highly unlikely that you're going to encounter somebody like that, because nobody wants to eat to that point or feel that way. So why does it happen? Why are sleeves big? Why are they dilated or stretched out? They're just made too big to begin with. You have to commit, I have to commit to making this really small in order to be effective long-term, right? So why? I mean, if everybody knows that, then why isn't that just kind of the standard? And I think it's getting better, but here's why. In every industry, it doesn't matter like what industry you're talking about. There's always going to be little shortcuts, right? I'm sure in like car mechanics, hopefully your pilot, is not doing that kind of stuff. But everybody identifies little ways to make things faster, easier. Surgery is no exception. And I kind of feel like surgery should be like your airline pilot. Like hopefully nobody's taking any shortcuts, but it's not uncommon to see sleeves that look like this. just a straight line. And I know that that doesn't seem substantially different than what I drew, but it makes all the difference in the world, okay? Because the one I drew starts out close to the pylorus, just a few centimeters away. And this one starts several centimeters away. The one I drew, it ends as narrow as the esophagus, right? It doesn't include any of this portion up here. Remember I said this part up here, the fundus of your stomach is exceptionally stretchy and thin. And so even a small dog ear of that fundus will balloon out over time. Yeah, you don't have to abuse it. It's just that's what it's for. It's supposed to stretch to accommodate food. So this portion that doesn't seem all that big at the time, give that a year or two, and all of a sudden this is stretched out like this, okay? Becomes a big dilated portion of your stomach. This portion, this seems pretty benign down here, but this portion, if you don't get it close enough to the pylorus, the outlet, this actually becomes a fairly large reservoir for food as well. And so instead of being 150, now some of these can get to 450, 500 cc's and beyond. They've clearly shown that if a sleeve is 250 cc's or greater, that it's associated with less weight loss and a harder time maintaining that weight loss over time. So usually if you study these, if you have people drink contrast or you pass the scope down to take a look at it, it looks like an hourglass, and it's not supposed to. It's supposed to maintain that normal, smooth, tapered consistency from top to bottom. So these people are the ones they're blamed for stretching it out. And in reality, it really had more to do with the surgery itself. I'll be honest, if you get a sleeve like this, you will lose weight in the beginning. There's no doubt, because it is a smaller stomach, right? Smaller than what you started with. But over time, that'll become an issue. It'll become an issue with weight loss. Not like a life-threatening issue, just kind of less than optimal results. Patients are generally happier with this in the beginning because they're not struggling as much. It's bigger capacity. They don't, they kind of, they get through the first 2 months and, it's not easy, small stomach, but they kind of get through it easier because this is a larger capacity sleeve. And they're still losing weight because it's substantially smaller than what they were working with before. My guys, by comparison, I think they'll all tell you that the first 2 months for them really suck. And I acknowledge that it's not pain or immobility. It's that they're so not interested in eating and drinking that they find it hard to just do the basics, stay hydrated, drink enough protein, take vitamins. They're so full just trying to do that there's very little room for anything else. And they really kind of have to devote a lot of time and attention to just doing the basics, hydration, sip on things slowly throughout the day. When you're adding back solid food, at first they'll do little nibbles. And when they first start adding it back, they're maybe full after 1 or 2 little bites. So the first 2 months is no one's idea of a good time. It takes my patients about 2 months to get to the point where they're eating and drinking with like enough ease to where they actually start to kind of enjoy eating and drinking again. Okay. They lose a lot of weight in the first 2 months, and that's the only exciting part. But I always tell them, I'm like, look, just don't despair, because it's not going to go on forever. It'll pay dividends in the long run. Just hang in there, just keep working on the basics, and it'll get there. And then, honestly, my guys, they all get to the point where they do everything everyone else does. They go to restaurants, they go to parties, they drink, they drink coffee. They all get there, but just don't get in a hurry. And they're not suffering from hunger. It's actually quite the opposite. It's actually like they're so not hungry that it's hard to do that at first. I'd rather take a patient who's like tired and cranky for 2 months than somebody who like is coming back to me 2 years later being like, hey, what happened here? So I end up doing a lot of these revisions. I'll tell you that first thing I do is I have to demonstrate what the volume of the sleeve is. And then I will, if I can get insurance to approve it, then I'll go in and I'll completely re-sleeve it to like 150 cc sleeve. Sometimes I'll do that and convert it to something else, but I'll go over that in a minute. Okay. So yeah, so that's one of the, that's very few actual life-threatening complications related to these, but I actually kind of see this as a complication. As to why they wouldn't just kind of take it in further, because as you get closer to the pylorus, it gets harder and harder to dissect off the fat and blood vessels on this lower portion of the stomach. So as you move farther this way, you got the head of the pancreas here. It just takes a lot more work and it's a little more risky to do it. Takes some time. Same thing here. As you approach the esophagus, that's where you start to actually encounter like some actual potential for danger. Out here, it's all free and mobile, and it's like, you know, it's like lots of people could do that. That's not the problem. Up here, the esophagus is pretty delicate. You got to be careful. Dissecting this out completely. A lot of people just rather avoid that, any potential issues or problems related to that. So it's just easier to just cheat a little bit out here and keep your staple line where it's relatively free and mobile and easy to dissect. So that's why you don't always get this, you know, a tight, narrow sleeve where you this. Plus, a straight line is easy to create. Okay. Straight is easy. Curve following the lesser curvature of the stomach, you know, that takes a little more arts and crafts, a little skill, I think. So straight, easy, curving line, a little harder with the staplers. Anyways, that's my little spiel, but I do a lot of revisions, probably more than anyone in the state. So I feel entitled to complain about it. Okay, so I'll get to the final operation that I'm very fond of. I like this operation a lot. Again, most patients who come through my program, they like this, they go with that, they do great. Most people will lose about 70% of their excess weight. Okay, imagine whatever you could consider 70% excess weight on your body. That's about what you could expect on average. Some people lose more, sometimes they lose less. Average is about 70%. Nobody becomes too skinny. Okay, nobody becomes too skinny with this. It leaves you with a nice enough buffer. If you want to get leaner than that, and I have patients who do want to get leaner than that, but if you want to, then it requires some effort. It requires some intent and purpose to do that. It won't just happen. Like too lean just doesn't happen by accident. Okay. The last one. I don't know if can you guys see this part over here? Okay. All right. So the last part, you've got, this one's called a duodenal switch operation, right? I favor this operation. I like this operation. I don't favor it more than that, but I still, I recommend them equally, and then I let patients decide what appeals to them. Okay. But this operation, we start with a sleeve, right? We do the sleeve just like every other sleeve. Okay. Same thing. No bigger, no smaller sleeve. This part's all gone. Now we're going to take it one step further than this, because this is just restrictive. We're actually going to introduce some malabsorption, somewhat similar to the way this one works. Okay. What we do is we're going to reroute the small intestine. Normally, food would exit through your pyloric valve. It mixes with the bicarbonate from the Brunner's glands, and then boom, all the way through your small intestine. Bile and pancreatic juice enter right about here. Normal. I'm going to interrupt that. I'm going to divide the small intestine right here. Okay. Right there. I'm going to keep the pyloric valve. I'm going to keep the first part of the small intestine that has the Brunner's glands. I'm going to divide it right here. I'm no longer going to let food start at the very beginning of the small intestine. I'm going to reroute it. I'm going to bring up the small intestine. I'm going to march down about halfway down the small intestine, and I'm going to bring it up and I'm gonna sew it to the end of this, so that when food leaves the stomach, it'll enter your small intestine about halfway downstream. Okay, so I'm gonna make it so that it can't go through your whole small intestine. It'll go through the second half of your small intestine and then make its way to the colon and out. Okay, what does that look like? That looks like this. And get rid of gastric bypass. It ends up looking like this. You've got your esophagus, you've got your sleeved stomach, okay, right? You've got the pyloric valve, got the small intestine here, or the first part of the small intestine. I'm going to bring your small intestine up in a way that looks like this. Okay. This will go all the way down to your colon, okay, and out. Food exits right through there, all the way through the rest of the small intestine, then to colon. All the digestive enzymes, they're still going to be there, but they're going to traverse through this first part of your small intestine. Ultimately, this is this. Okay. All the bile and pancreatic juice travel through here. As the food exits your stomach, it mixes with those enzymes, then real digestion occurs. But it's by that time, it's already about halfway through. So what does that mean? Well, it means that you're going to eat like a sleep person, just like a sleep person. But then once your food leaves your stomach, you're only going to absorb about 85% of what you ate. About 15% of what you ate is going to make it all the way through your body and out without getting absorbed. 15% doesn't really sound like a lot, but 15% of every meal adds up quite a bit. So you don't want it to be more than about 15%, because you don't want too much undigested food making its way into your colon and through your colon, because you have a lot of bacteria in your colon, and the bacteria in your colon will go to work on that food and turn it into horrible gas and diarrhea. So you don't want it to be too malabsorptive, you know. And this operation has been around for a very long time, but the way that this used to be done is they used to make it very malabsorptive. It wouldn't bypass half of the small intestine, it would bypass most of it. And that was the concern, that was the problem, is that people got too skinny and they would be plagued by excessive gas and diarrhea. And it was just, I don't know, it was just, people lost interest in it until somebody got the bright idea, I don't know why it took so long, to just make it less malabsorptive. So now it's, over the last few years, it's really enjoyed a resurgence in popularity. And I like it a lot. The average weight loss is still about the same. It's still about 70%. That's when you take an average everybody. My personal feelings about it is that I do find it, I think it's a little bit easier for patients to lose weight. I think it's a little easier for them to maintain the weight loss. And this has been shown to be the most durable operation over time in terms of maintaining the weight loss. This also has a little bit faster resolution of diabetes. They all kind of get to the same place when you're talking about diabetes, but this one actually has a little bit faster resolution than, like, let's say the sleeve. The sleeve will get you there, but this will do it a little faster, okay? Why would people select this over this, or this one over this one? It comes down to personal preference. I'll tell you, 80% of people just are totally comfortable with the idea of having a smaller stomach. Not so much when you're talking about rerouting the small intestine. So only about 20% of people are okay with that, or good with that. Most people say, I just need a good tool to help me lose weight. I don't want to alter my anatomy too much. So that's why I think this is so appealing.
this is, trust me, this is hard enough for people. This feels I think that this feels exactly the same way that this does to them. But committing to this extra stuff is not always as easy as you think. So I always tell people, I'm like, just because this kind of, you got to be really comfortable with that idea. You don't want to try and talk yourself into one procedure or the other. Most people, when they look at it, they can make a snap decision. Like, I know which one I like. I know which one I'm not sure about. You don't try to talk yourself into something you may not be comfortable with. That's my advice I give to my patients all the time. Okay. I like them both. They both carry the same low risk. I don't have any more problems with this one than I do with this one. I don't see any new issues or long-term problems with this one. I do feel it's a little bit more important for these guys to be observe that vitamin intake. Okay. I have them take the same vitamins that I have them take for this. That's a daily multivitamin that has iron in it. So a multivitamin with iron, calcium plus vitamin D. Okay. That's it. That's all they need. They can do more if they want, but that's all they need. And I have the DS patients called duodenal switch. I have them take the same vitamins. No difference. I just feel it's more important for them to be good about it. If these guys don't do it every day, it's not the end of the world. I want them to do it, but if they don't really have lab abnormalities and things like that. The recovery is the same. Where I place my instruments is the same. The instructions are the same. There's really, I don't treat these guys any different than the sleep patients. So I like it, but again, not everybody's totally comfortable with this idea. Okay. Why is it better than a bypass? Because it still has your pyloric valve. It still has glands that neutralize the acid after, after it leaves your stomach. You don't get marginal ulcers, strictures. It just works. I like it. What about questions? What about any questions about anything I've gone over? Oh,
We'll start with the online questions so that they can log off online, and then
anything you want.
you'll hear stuff.
You guys ask me anything.